So welcome everyone. My name is Dave Walton, and today we're going to take a journey back in time for most of us in an attempt to remember some of the biomechanical terms and concepts we learned in our early days as PT undergrads. The purpose of this lecture is to review some of the common terminology used when discussing biomechanics, really to facilitate future discussions in this area. We'll start by defining the terms kinetics and kinematics, since we can't have much of a biomechanical discussion without really understanding these terms. Kinematics, in a nutshell, refers to the description of the movement of an object through space. We might use planes of movement or vectors when describing movement kinematically. What we are not referring to are the forces which cause the movement described. The forces that cause movement are the domain of kinetics, which include torques and moment arms. We'll be discussing phenomena from within both of these disciplines during our talk today. Starting with a kinetic term, we need to be familiar with the concept of torque. When we're discussing the motive force behind objects moving in an arc, we're discussing torque rather than force. Very simply, torque is the product of the perpendicular vector of force applied to a rigid body multiplied by the distance between the point of application of that force and the axis of rotation. Not sure that was so simple. Basically what this means is that for a given force, the farther away from the axis of rotation you apply that force, the greater will be the torque. This is the reason that we can lift 200 pounds of topsoil in a wheelbarrow, which we could otherwise not do on our own. Moving further with this concept, we can consider the idea of mechanical advantage. First, we must appreciate that there are no naturally occurring circumstances on Earth in which there is only one force acting on an object. The simple act of bending our elbow depends on the interplay of forces from our muscles, ligaments, joint friction, gravity, and whatever we might be holding in our hands. We could classify these forces into two broad categories, either muscle force, which help the movement, and resistance force, which resist the movement. Going back to the idea of torque, we can look at the distance from the axis of rotation that each of these two forces are acting. If both were equal distances from the axis, then the muscle would have to produce exactly as much force as the resistance in order to keep the arm stable. In that case, there is no mechanical advantage for the muscle. If the muscle force were applied to a point farther from the axis than the resistance force, then the muscle wouldn't have to produce as much force to keep the arm stable, and would therefore be at a mechanical advantage. If, on the other hand, the resistance force was applied farther from the axis than the muscle force, the muscle would have to produce much more force than the resistance in order to match that torque, and we would therefore say the muscle is at a mechanical disadvantage. I've mentioned the word vector previously, and want to make sure that we're all clear with this concept. Force is a vector quantity, which means it must always be described by magnitude and direction. If a muscle, say the biceps, pulls on a bone such as the radius, it usually does so at an angle away from the perpendicular. We can break the force down into vectors, and in this simple illustration we can see that there are two vectors to this force. One is the perpendicular force, which will tend to rotate the arm, and the other is a compression force directed posteriorly towards the joint. For our discussion of torque, we are only interested in the perpendicular vector of this force. A more in-depth discussion on torque and mechanical advantage can be found in the auto lecture on myokinetics and myokinematics. I apologize in advance for that one. I was young and I needed the money. Anyway, let's now turn our attention to levers. There are three classes of levers that we traditionally refer to in biomechanics. Those are first, second, and third. A first-class lever is one in which the axis of rotation falls between the muscle force and the resistance force. In order to maintain an equilibrium here, both forces must be acting in the same direction, such as they are in the example of the seesaw we see. The muscle can be at a mechanical advantage or disadvantage with a first-class lever, dependent entirely on the distance from the axis that each of the muscle force and resistance force are acting. First-class levers are fairly rare in the human body. Two examples that spring to mind. One is the occiput on C1, where the axis of rotation is the external auditory meatus. The center of mass of the head is just anterior to that, and the suboccipital muscles are just posterior to that. A second example would be at the talocrural joint. If you were lying prone with your knee flexed up 90 degrees, then the axis of rotation would be right at the joint itself. The center of mass of the foot would be just anterior to that, and the triceps surae muscle group would be just posterior to that. Second and third class levers have both the muscle and resistance forces acting on the same side of the axis. In a second class lever, the muscle force is applied farther away from the axis than is the resistance force. This means that in order to maintain equilibrium, the muscle need not produce as much force as is being produced by the resistance, given its mechanically advantageous point of application far from the axis. While this arrangement is efficient in terms of muscle force, it is actually inefficient in terms of movement, as it would require a lot of muscle shortening in order to bring a limb all the way through range. The only example of a second-class lever in the human body that comes to mind would be that of standing on the balls of your feet. Here the axis is the ball of the foot, or the MTP joints. The resistance force is coming down through your tibia, and the muscle force is the triceps surae group. Finally, in a third-class lever, the resistance force has the advantage in that it is applied further from the axis than the muscle force. This means that in order to maintain the equilibrium, the muscle must produce more force than the resistance, as it is now at a mechanical disadvantage. While inefficient from a force standpoint, this is an efficient arrangement in terms of movement, as a small change in muscle length will result in a relatively large arc of movement of the distal part of the limb. The third-class lever is by far the most common type of lever in the human body for this reason. The biceps are a classic example of a third-class lever. Here, the axis is the humeral ulnar joint. The resistance force is located at the center of mass of the combined weight of the forearm and any object being held in the hand, and the muscle force is applied at the insertion of the elbow flexors on the radius and ulna. Let's now look at a practical application of some of these concepts. This is B-Boy Junior, a breakdancer from France. This video, along with several others of Junior, can be found on YouTube. Let's just watch him do some plank push-ups.
Eh ben, je m'arrêterai pas tant que vous n'enverrez pas des courts-métrages pour le Hip Hop Short Film Festival organisé par Hairstyle.
Let's take a quick look at some of the biomechanical principles of this incredible feat of strength. I'm going to take one still picture of one of his no-feet plank push-ups and convert it into a simple line drawing, analogous to a crude free body diagram. The first thing we see are several axes of rotation here about the different joints. We're going to focus on one about the shoulder. The center of mass of the human body is somewhere around the first or second sacral vertebrae, depending on body shape. Because the axis of rotation is the shoulder, we also have another center of mass to consider, that being the head and neck. Now, because the lower half of the body is so much heavier than the head and neck, the overall center of mass of this body is below, well below the axis of rotation, which would of course tend to pull the body downward, were it not for the clearly incredible strength of Junior's anterior deltoids. In this case, they're working in a reverse origin insertion fashion, keeping the lower half of the body off the ground, rather than their traditional role of flexing the shoulders. Now, because we have forces acting on either side of the axis, Junior is currently a nice demonstration of a first-class lever. As an extra tidbit of information for you, Junior had polio as a child, and as a result, his right leg is much smaller than his left. This will have the effect of moving the center of mass of the lower half of the body a little closer to the axis of the shoulders, thereby slightly reducing the resistance torque and making this movement slightly easier for him. Regardless, this is still clearly an exceptional display of strength. We'll now move from a discussion about the kinetics of movement to some kinematics. Specifically, we'll start by talking about osteokinematics, or the motion of a bone in space, without regard to the movement occurring at the joint surface, which would be termed arthrokinematics, or the force causing that movement, which would theoretically be called osteokinetics. When describing the movement of a bone, we can usually describe it by its direction within at least one, and often two or three planes of motion, as well as the axis around which the bone is rotating. Osteokinematically, we often describe flexion, extension, ab or adduction, and internal or external rotation. I have used the term center of mass in the earlier slides on kinetics, but have yet to truly define it. It is relevant to do so now as we talk about axes of rotation. To begin with, there are traditionally two axes of rotation described for a bone or joint. The first is often called the anatomical axis of rotation, and this is the center of mass of the bone. The second, and the one we are likely more familiar with, is the mechanical axis of rotation, which I will describe further in a couple of slides. The center of mass, or the anatomical axis of rotation, is that point about which an object would spin if you were to throw it in the air and watch it spin. Rather than describe it, let's watch two physicists from MIT demonstrate the concept. Starting with spinning of objects in bright light against a white background, we can see that these objects, each with their center of mass closer to one end than the other, appear to travel a somewhat wobbly path as they are spun. We see a tennis racket, some kind of a stick with a weighted ball on the end, and what appears to be a weighted frisbee of some kind. Now look at the difference when the same objects have their center of mass highlighted with an orange marker and are viewed under a black light. Despite the fact that we know the object itself looks wobbly as it is spun through the air, the center of mass, being the point on the object where all net rotational forces are zero, travels through the air with a gently curved trajectory. In contrast to the anatomical axis, the mechanical axis of rotation is probably more important to us as we are rarely dealing with bones in isolation. The mechanical axis is that point around which a bone will move when it is attached to another bone or bones. To illustrate, in the picture on the far right, we see the anatomical axis of the femur, at least if it were to be spun lengthwise. The middle picture shows the mechanical axis of the femur for internal and external rotation. Note that this is the same line as the ground reaction force, which is the force being transmitted through the leg to the superior acetabulum with every step we take, an application of Newton's third law. Note that the mechanical axis of rotation is generally about perpendicular to some aspect of the joint surface. In the picture on the left, we see that for internal and external rotation of the tibia, the mechanical axis, being perpendicular to the femoral joint surface, is about the same as the anatomical axis, as this is a relatively well-balanced bone. In physiotherapy, we generally describe movements with respect to the mechanical axis of rotation. Speaking of describing movement, it is worth a moment to review the planes of motion available to us. We generally describe three planes of motion within which the body moves. The sagittal plane separates left and right halves of the body, and is the axis for flexion and extension movements. When the sagittal plane lies directly down the midline of the body, it is sometimes referred to as the mid-sagittal or median plane. The frontal or coronal plane divides the body front and back. It is the plane in which the movements of ab and adduction occur. Finally, the horizontal or transverse plane divides the body top and bottom. It is the plane in which the movements of internal and external rotation occur. To fully describe movement osteokinematically, we must always make reference to both a plane of movement and an axis of rotation. There is some confusion that exists regarding axes of rotation and how they should be named. The problem is that each axis lies in at least two planes of motion. As an example, for motion occurring in a sagittal plane, such as flexion or extension, we could try to describe the axis as lying in a coronal plane. But since an axis is a straight line, we could just as accurately say that the axis lies in a transverse plane. For this reason, some biomechanists have proposed the following terms for describing axes of rotation. For movement in a sagittal plane, the axis of rotation should be called either a transverse axis, or perhaps even more friendly, a medial lateral axis. For movement occurring in the frontal plane, the axis of rotation can be called either sagittal or antero-posterior. And for movement occurring in the horizontal plane, the axis should be termed a vertical axis, or infero-superior. Getting this terminology correct will facilitate further discussion around osteo and arthrokinematics. Now that we have described osteokinetics and kinematics, we will turn our attention to arthrokinematics, or the study of the movement of one articular surface on another without reference to the forces producing that movement or the movement of the long bone per se. Arthrokinematics are often described in association with the resulting osteokinematics, however. Arthrokinematically, we generally describe three types of movement. These are slide or glide, rock or roll, and spin. If we consider that most joints consist of one relatively round surface and one relatively smooth surface, we can imagine that at any time there is only one point on the moving bone that is in contact with one point on the stationary bone. During a slide, then, we can say that a single point on the moving bone comes into contact with several points on the stationary bone, just as the same part of the wheels on a skidding car with locked brakes will make contact with several points on the road. A roll can be described as a movement in which several points on the moving bone come into contact with several points on the stationary bone, analogous to the wheels of a car driving along a dry road with good traction. The term rock, though not frequently, is sometimes used to describe a small amount of roll. Finally, a spin can be described as a movement in which multiple points on the moving bone come into contact with the same point on the stationary bone, analogous here to a car spinning its wheels on an icy road but not moving. During normal joint movement of an ovoid surface, slide and roll must occur together for full range of motion to be available. When the moving joint surface is convex, the roll occurs in the same direction as the movement of the bone, but slide must occur in the opposite direction in order to keep the joint surface centered over the stationary bone. When the joint surface is concave, slide and roll occur towards the same direction, although slide is the dominant movement here. Spin can occur in either direction independent of slide and roll. Looking at the example of extension between the tibia and femur, starting with the picture on the right, we can see that when the distal limb is not fixated, a movement which we sometimes confusingly refer to as open kinetic chain movement, the tibia is a concave surface moving on the convex femur. The slide and roll both occur in an anterior direction, with a conjunct spin that is independent of the direction of slide or roll. When the distal part of the limb is distally fixated, which we might even more confusingly refer to as a closed kinetic chain movement, we can see now that the convex surface of the femur rolls anteriorly on the tibia, but in order to maintain joint congruency, it must also slide posteriorly. Again, the spin occurs independently of these two movements. Take a moment to think about the mechanics of a joint when roll is allowed to occur without the conjunct slide, as is sometimes the case in restricted joint motion. We can see that not only does the joint risk becoming unstable, but structures on the joint side in the direction of the roll risk compression, whereas structures on the side opposite the roll risk distraction injury. Another important consideration when talking arthrokinematics is the concept of degrees of freedom. In its simplest conceptualization, degrees of freedom refer to the number of axes about which a joint is able to move under normal circumstances. Joints with 1 degree of freedom are limited to movement about a single axis, such as flexion and extension occurring about a medial-lateral axis at the humeral ulnar joint. Joints with 2 or more degrees of freedom may have a spin available in addition to the swing, or may have 2 distinct swings. In joints with 2 or more degrees of freedom, the axes of rotation for each of the movements must be perpendicular to each other. The MCP joints have 2 distinct swings, flexion extension and ab and adduction. The small amount of spin that occurs with these movements is not under voluntary control and is therefore not considered a 3rd degree of freedom. The knee is an example of a joint with 1 swing, flexion extension, and 1 spin, internal and external rotation. A joint with 3 degrees of freedom, such as the hip or shoulder, must have a spin associated with 2 cardinal swings. Again, the axes of rotation for each movement must be perpendicular to each other. Joint shape influences the plane of movement, the axes of rotation, and the degrees of freedom available at each joint. An ovoid joint has 3 degrees of freedom, and a sellar joint has 2. Modifying either of these joints results in the loss of 1 degree of freedom. Now that we are all speaking the same language regarding kinematics of the bone and joint, there is one more osteokinematic concept we need to revisit, and that is the notion of swing. Now, the concept of swing is not difficult. Anyone familiar with a children's playground will understand that we're talking about the arcuate path of a bone. What is somewhat more confusing are the different types of swings in biomechanics. We can describe 2 different types of swings, pure and impure. A pure or cardinal swing is one that occurs without any accompanying spin. In other words, the bone is able to move in only one plane of motion. A pure swing requires the joint to have at least 2 degrees of freedom, and while not uncommon in the body, pure swing is functionally abnormal in that normal voluntary movements rarely occur in just one plane unless we are intentionally trying to do so. say for example during a demonstration of pure swing in a biomechanics lecture. An impure swing is more functionally common and useful. An impure swing is one that occurs with an accompanying conjunct spin. Thinking about your first MTP joint, if you were to try to flex or abduct your thumb without allowing the spin to occur, you would be restricted in your range of motion. These spins are important to observe during movement in order to identify abnormalities that might be limiting range of motion. To round out our discussion of basic biomechanics, it's worth discussing the various types and names for rotations in the human body. I personally find the distinction between these names to be somewhat vague and confusing at times, but I've tried to describe them here in a way that will demonstrate the unique differences. We will describe three types of rotations: adjunct, conjunct, and congruent. Starting with adjunct rotations, these are rotations of adjacent body parts that usually occur in the same general direction, which are done more for ease of movement than anything else. There's no anatomic reason why adjunct rotations must occur, and they can be done or undone voluntarily. An example of an adjunct rotation is the relative supination of the forearm that tends to occur during shoulder abduction. We don't always supinate the forearm when we abduct our shoulders, nor do we need to, but when we do, it tends to feel easier or more natural. Conjunct rotations are distinct from adjunct rotations in that conjunct rotations occur because of some anatomic reason. This might be the shape of the joint surfaces or the surrounding soft tissues that tend to pull the moving bone into a rotation during swing. Examples here are the external rotation of the tibia at terminal knee extension, or the internal rotation of the thumb during abduction. If conjunct rotations are not allowed to occur, full range of motion will not be available. Congruent rotations are the final type, and there is definite overlap in this definition with that of adjunct rotation. If adjunct rotations occur for ease of movement, then congruent rotations occur due to habitual central patterning. Central pattern generators are found in the spinal cords of animals and possibly humans, which influence congruent rotation to a certain extent, such as the external rotation of the leg during the swing phase of gait. A simple example that you can try is external rotation of your shoulder. Try it first with your forearm supinated and your wrist radially deviated. Next, try to externally rotate your shoulder with your wrist ulnarly deviated. How does that feel? Now externally rotate your shoulder with your forearm pronated. While it is certainly not impossible to externally rotate your shoulder with your wrist ulnarly deviated or your forearm pronated, and the available range should be about the same, it just feels much more natural to do so with your forearm supinated and wrist slightly radially deviated. These are examples of congruent rotations, movements that occur because the central motor patterns are soft-wired in this way. Codman's paradox is another example of a congruent rotation. Try this. Start with your elbow flexed 90 degrees and your arm internally rotated so that your forearm is resting across your stomach. Maintaining the internal rotation, flex your shoulder over top of your head. Your forearm should now be above your head, your elbow still flexed 90 degrees. Now, without rotating your shoulder, return your arm to your side, but through the adduction plane rather than extension. If you've maintained your 90-degree elbow flexion, you should now find that your shoulder is now in fact externally rotated, despite the fact that in no part of these instructions did I ask you to externally rotate your shoulder. This rotation occurred automatically as part of the normal movement pattern for bringing your arm back to your side through adduction rather than extension. This is Codman's paradox and is an example of dyadical movement. Another example of dyadical movement is this. Standing with your arm hanging by your side in a neutral orientation, thumb facing forward, flex your shoulders straight forward 90 degrees. Now, without rotating your arm, horizontally abduct your shoulder about 45 degrees through to the scapular plane. Now return your arm to your side through the scapular plane, maintaining the rotation. As per the last example, you should now find that your arm is externally rotated, despite your best attempts to maintain neutral rotation. If you now maintain your new position of rotation and try to repeat the cycle, you'll find that it becomes progressively more difficult to return your arm to your side as the external rotation becomes more extreme. A dyadical movement is simply a two-legged approach to moving a limb through range. The term dia, referring to two, and dokai, from the Greek word for successor, dyadical literally translates to two successive displacements. Since we are dealing with curved surfaces, those being joints, a diadical movement will involve a congruent rotation in order to bring the limb to the same final position as the single-legged movement would have. It's a phenomenon that tends to be of more interest to biomechanists than physiotherapists, but one might consider whether we could use the concepts of diadical movement and congruent rotation when trying to retrain weak movement, say for example, weak external rotation through the use of flexion and horizontal abduction. The next 11 slides are for your own self-evaluation. These slides will describe a movement and will ask you to determine the plane of movement and axis of rotation about which the movement normally occurs when a body is in anatomical position. Each slide will transition about every 10 seconds, but I suggest you pause the slide if you need more time to think about the answer before it appears. While you're working through these, why don't we listen to the song called Acoustic Alchemy by Norwegian Recycling, whose songs can be safely and legally downloaded for free from his website, which will be listed at the end of this presentation.
She's got a whole lot of reasons. She can think of a single one that can justify leaving. He got none, but he thinks he got so many problems, and he got too much time to waste. His dreams are like commercials, but her dreams are picture perfect, and our dreams are so related, though they're often underestimated. This is gonna take a long time. Can't take no more. Wonder if you understand. It's just a touch of your hand behind a closed door. All I needed was the love you gave.
To summarize our discussion today, clearly, rotational mechanics are indeed a different beast than linear mechanics. We are dealing with torques, spins, and swings rather than forces and linear displacement. However, I hope that we can adopt a common lexicon in the field of orthopedic physical therapy to help us communicate ideas about some of these concepts. I wish you the best of luck with your educational pursuits from here on out. I'm Dave Walton.